Everyone, how's it going today? Hopefully y'all can hear me. Hello, everyone. Hey, Aaron, Allison, Nicole, thank you for joining me today as usual. Aaron, good to have you all here. We can start in a couple of minutes. Continue our talk about diabetes. Koji. We're all having a wonderful day so far. I don't think, did you have an exam today? I don't think so. It's always a good day if you don't have an exam. Aaron's with Elizabeth, Nicole, Molly from Blendflex. I'll accept it. Yeah, right? Did I Blendflex and no exam. That's always good. I'm looking around a bunch. I'm just trying to make sure I don't have anything on my computer's going to go off and make a bunch of noise or something weird. Although both my children will be here in just a little bit, so you hear a lot of screaming and tantruming. That's what that. It's not your subconscious screaming out, having to listen to me. About 21 people in here so far. It's pretty good. Shelby? Shelby, I keep waiting for you to like correct me on something. I always was like I mentioned, having the nutritionist, dietitians in class, because they can always catch me on stuff if I misspeak about something. So if I misspeak of something with the diabetes, Jackson imagines me having a 9-monitor setup, looks like mission control or something. It's like you ever seen that movie what is it, Swordfish, with Hugh Jackman? It's like his little hacking setup. So I got about 14 monitors all surrounding me. Full swivel chair that can go full 360. I just don't utilize it for this class. You know, you've never seen me or Batman in the same room at the same time, so who's to say? I can neither confirm nor deny it. Although with my some of my professional credentials, DABAT, some people have called me Da Batman before, but it's a term of endearment or ridicule, I guess. I don't know. Hey, Kelly. I just have my nice 2-monitor setup. I was looking to buy like a big giant widescreen one since the pandemic, but a lot of people were buying all those monitors up, so they're kind of inordinately expensive. But here we are again today, so let us begin here. I did have a question that popped up. Someone was asking about if I could clarify what I was saying about patients with renal failure and what happens with their insulin. Basically, they cannot clear it as well, so they have higher insulin levels relative to what they would normally have if they had their kidneys functioning normally. And so then basically they can't clear it, so their levels of insulin go up, so that makes glucose go down. So that's why it can be difficult to control sugars in that patient population too, especially like the critically ill patients. They can be a real challenge because not only do you have potentially issues of insulin clearance, but more often than not, they're in a state of sort of critical stress, and that releases a lot of corticosteroids, cortisol primarily, and so that's where you're going to see actually the sugars rise because of that. So it's not uncommon for like ICU patients to require things like insulin drips just to keep their sugars under control, because we do know, especially with like septic patients and stuff, if they're hyperglycemic, it tends to worsen inflammation, worsens infections, and things like that. So glycemic control is really important. Yeah, in the ICU, consider anything less than 200 good. Yeah, so you may have like a little bit of a a threshold that you'll go with, but it's just depending on the situation, you may require that. Someone said, I find it impressive you're taking time to recognize your names and faces, especially with you teaching in multiple schools. Listen, you guys are my home. You guys are, I'm always Nova full time, so you guys are my family. So we'll just leave it at that. Anyway, so let us continue on. And of course, I lost my slide. That's no good. Let's get back to. Or I should have done this beforehand. That would have been the professional streamer thing to do, right? So we talked about biguanides, talked about the TZDs, alpha glucosidase inhibitors. Yeah, I'm Nova all the way. And I tell you what, if I had to, they talk about like if you find the job you love, you never work a day in your life. I always thought that was such garbo. Like I was like, no way, that's not true. I would rather just not work at all. But no, I love teaching. So even if I won the Powerball tomorrow, I might drop some side hustles, but I'd still be here probably till I retire, whenever that is. But anyway, so shark all the way. But so we were talking about kind of the balance there between insulin levels and type 2 diabetic patients. We're talking about how insulin levels, especially as they wear out that pancreas, that their insulin levels eventually will die down because they just can't produce as much insulin as they used to. We talked about glucagon levels that actually stay sort of disproportionately high. Glucagon levels stay high because of the fact that they don't have that natural response that, normally like a patient with normal glucose tolerance, if they have a big bolus of glucose due to food or something, you would actually find that their glucagon level should drop, which makes sense because, glucagon doesn't need to produce glucose from the liver if you have it coming in exogenously. So there's another hormone that really is at play here as well, which is really interesting, and this is called the incretins. We'll talk about incretin-mimetic drugs, or drugs that mimic the effects of incretin. And so basically what you can see here is that this is a hormone that specifically responds to oral glucose intake as opposed to any other form. And so you can see an example here. If you were to look at, say, plasma glucose levels from either an oral or an IV bolus, you would see that they have pretty similar levels there. But what's really cool is that when you have this white line here, this is oral glucose. You find the incretin levels spike significantly here with the actual oral glucose coming in versus if you were just to have an IV dose of glucose, you would not see the incretin spike up quite as much. And so this is going to be really important because this has a lot to do with things like GM motility. It has some stuff to do with satiety, and that's going to be really important for these patients, as we'll see here in just a moment. Someone says, can you take off your jacket so I can blend into the background and become a floating head? This is actually just a mannequin's body that I put underneath me. My head is actually floating all the time. I didn't want to freak anyone out. So anyway, so going back to the incretins, we'll find that incretins kind of like a broad sort of category. And so under that, the main one we're going to talk about is glucagon-like peptide 1. And you can see here it's a relatively short half-life, and it primarily spikes up after mealtime glucose, meaning PO glucose that you're intaking from the GI tract. You'll see being secreted from some of these L cells in the intestine there. And basically what this helps to do is to stimulate insulin release from the pancreas. It will decrease gastric emptying, and it also triggers those little satiety receptors you have up in the brain that say, hey, we have enough food here, we don't need to intake anymore. Which you can imagine might be pretty handy for a lot of type 2 diabetic patients. One, it cuts down on their glucose intake and their carbohydrate intake, but also it cuts down on overall caloric intake. And a lot of these patients are overweight or obese, and so this might actually be a good thing, as we're going to see here in just a little bit. And you'll see also GLP-1 helps out with things like the release, the biosynthesis, and also the gene transcription for insulin. So overall, helping to get more insulin production here. You'll also see that it gets metabolized by this enzyme called dipeptidyl peptidase 4, or DPP4. This will be important for one of the drug classes we'll see here in just a moment. So again, this is a nice picture kind of showing you some of the different functions of GLP-1 and what that does for us. So here again, it will be secreted normally when you have ingestion of food, and when it's going to help out with glucose-dependent insulin release, which is good because that'll get our sugars down. It will help to regulate gastric emptying, so it actually slows that down, so you feel fuller faster because that food's just kind of hanging out there in the stomach. You get less glucagon, and you're going to get promotion of satiety there and reductions in appetite, all which sounds really good for a diabetic patient, which is why these are pretty powerful drugs we have here. And it's a relatively new class in the grand scheme of things. And you'll find that not only will type 2 diabetic patients have diminished levels of insulin after, say, a big ingestion of carbohydrates and glucose, but you're going to find they also have reduced levels of GLP-1. Okay, so that's what the other kind of one of the big problems is they have less GLP-1s. That's probably contributing to the fact of why they have less insulin and they have more glucagon that is sticking around after mealtime. And so if there's some way we could try to either mimic the effect of GLP-1 to replace maybe what they're not producing, or if we're able to maybe decrease the metabolism of the GLP-1 that they have, then perhaps we could mimic some of those effects and help out with their overall glucose control, as we'll see here. So that's all really going to be helpful there. And again, as we saw last time, the glucagon levels stay pretty high for these type 2 diabetic patients after glucose intake, and maybe some of that is related to the GLP-1, and that's kind of what has been borne out in the evidence that we have so far, right? And you can see here, this is what levels of GLP-1 would look like in someone with like normal glucose tolerance versus impaired in type 2. You can see that it's certainly greatly reduced. And so if we can do something to bump up those levels, again, either by replacing it or by preventing the breakdown, we should have higher levels and get kind of closer to what our normal would consider to be in a typical healthy patient. So some of you might be wondering, why do I put a picture of a lizard here on the slides, actually from the Gila monster, a picture of a Gila monster, and this is actually really cool. These are going to be the Incretinmimetics. And the first one that we had here was a drug called exenatide, or Byetta is the brand name. And interestingly enough, as we found, and again, I don't know who the scientists are that figured this stuff out, but I think that might be a fun job, just to like pick a random animal and try different like bodily fluids to figure out like, okay, can we use this for drugs? Maybe, maybe not. But in this case here, we found that the saliva of a Gila monster has about 53% homology with our GLP-1. Again, why does that happen? Yeah, salmon sperm, Gila monster saliva, equine estrogens. I mean, where does it stop next? And we're going to have like llama spit or something, or llama bile. We get bear bile. That's where we got our Actigol, right? So lots of different cool sources for drugs here. But it is pretty homologous with our GLP-1. And we find that it does have some cross-reactivity. And so what we would use this for, again, because it's a protein, it does have to be an injectable. So that's going to be one of the big things with the incretins is this is our first sort of injectable medication specifically for type 2 diabetes. And you can see that this would be used in conjunction with things like metformin or maybe like sulfonylureas for patients who are maybe on those meds but aren't yet well controlled. And interestingly enough, you'll also see a great amount of weight loss associated with this too, right? We think it's all the same scientists. Perhaps it's me. You have no idea. I'm just kidding. I'm not that old. But you can see here with exenatide, it wasn't ideal, even though it was the first one out, because you were having to inject yourself twice daily. And so very expensive. It was, just not ideal because they're still injecting themselves twice daily. And maybe they even needed some insulin as well. So not the best thing out there. And so, but as you can see here, you can look at the actual insulin response to oral glucose, looking at what, say, like a normal diabetic patient, or sorry, normal patient would look like. If you notice their insulin levels, how they spike after the administration of IV glucose, you can see here how in a type 2 diabetic patient, how this would look in placebo. They have very relatively low levels of insulin, and then you give them the exenatide, and it boosts up and almost looks identical to the patient without diabetes. Pretty cool stuff when you see that, but from a administration standpoint, not ideal having to be stuck twice a day. So what we found is that nausea, vomiting is pretty common, and this makes sense because of the decreased gastric emptying. So you may feel that extra fullness, maybe have some reflux associated with that. Typically improves over time. You may find some hypoglycemia, but it's usually going to be in combination with other hypoglycemics like sulfonylureas. By itself, it typically is not super likely to cause hypoglycemia on its own. You may find some decreased absorption of other oral medications due to that slowed gastric emptying, so that could be one thing. And then the weight loss. Weight loss might be a good thing for some patients, may not be great for others. But again, a lot of these patients could probably stand to lose a little bit of weight at least, and so you'll get some benefit from that. And then rarely pancreatitis could be caused by this. So that would be something to certainly think about when you're looking at their medication list if they're presenting like with belly pain. So since then, we've got some better options here. We have things like liraglutide, dulaglutide, and albiglutide. Again, not quite the most eloquent of names, but you can see here that they're basically either more synthetic versions of this or closer to the human GLP-1 in terms of their amino acid sequence here, and they will do different things to try to make them have different pharmacokinetic profiles. So with like Victoza here, you can see it actually gets linked to this fatty acid that binds to albumin, and that helps to slowly release it and gives it a much longer half-life. So that one, I believe Victoza is like one time daily. You're getting stuck with the newer ones like Trulicity and Tanzium. It's actually once weekly injections, which is really awesome because they just have to stick themselves once and they get the benefits of that throughout the entire week. Whereas with exenatide, again, it was twice daily. So again, these will be expensive. You do run the risk of having, some allergic reactions to this, but overall, they're a great set of drugs. And I actually have some personal experience with this where I had an uncle who, I'm not sure if any of you are familiar with I think he's recently deceased actor, Wilford Brimley. He was on all these like diabetic supply commercials, like when I was growing up on TV. He's the diabetes guy. But I have an uncle that is just like Wilford Brimley, looks just like him. And to a large extent, and he was very much had type 2 diabetes, was overweight. That's not my uncle, but he looks just like him. And so but then he actually got put on Victoza, and it probably was a couple of months between when I saw him. I think I'd seen him at like 4th of July, and then I saw him at Thanksgiving, and he was just a shadow of himself. So Christy's saying we had a patient lose 60 pounds in a matter of a few months after starting Ozempic. It's one of the newer ones. And yeah, he was a shadow of his former self. I was just like, how in the world did he lose all this weight? And he was like, oh, it's the Victoza. So it was pretty fascinating. He actually ended up having to go into the hospital because he was actually developing some malnourishment because he just wasn't eating. He just had no desire to eat because that satiety was being so well activated up in the brain. So again, it can be a double-edged sword there. You do have to still consider their nutritional intake and making sure they're meeting their needs there, which is pretty cool. I don't see this often as monotherapy necessarily, Brian, but because these are going to be a lot more expensive, you probably want to try the simple things first. So if you can try metformin, which if anything is just going to, basically help the body use insulin more effectively, it makes sense to have that on board regardless if you're going to go on something like Victoza or any of these Incretins here. So pretty cool set of drugs, I really think. When would weight loss be bad for a patient? Someone was asking here. Again, if they're becoming malnourished, if they're not getting appropriate dietary intake of vitamins and minerals and all sorts of things like that. And again, it's possible to be too skinny, right? So that it can be the case there. And so again, you're talking about somebody who probably lost more than 50% of his weight, if I had to guess, or 40 to 50%. That's pretty drastic for that type of patient to lose that much weight. So again, it can be too much of a good thing in some cases. Now, before we had the Incretinmimetics, we basically were using these DPP-4 inhibitors, so trying to prevent the breakdown of GLP-1. These weren't nearly as effective as you would see with the Incretinmimetics, but you still may see them used occasionally because these are still orally bioavailable, which is handy from a compliance standpoint. And they'll also work on several other different hormones as well that may have some effects on different other incretin products like, glucagon-like peptide, GLP-1, and along with some other ones like protein or peptide YY, things like that. So just know that the biggest thing we're focusing on here is that they prevent the breakdown of GLP-1, and that's going to be our biggest purpose there for diabetes' sake. These are pretty easy to determine because they have gliptin at the end of the name. So like allagliptin, sitagliptin, saxagliptin, and linagliptin. You will not find the same weight loss with these as you do with the incretins because you're not getting the same, instead of like just, giving a huge dose of it that's replacing what they're missing. You're just helping kind of the little bit that they have out. So you can imagine it's not quite as effective as all that. But if you needed something oral, as opposed to an injectable, this might be a decent option there. And again, rarely can you see things like angioedema, anaphylaxis, some skin reactions, which rarely can result in Stevens-Johnson. So something to at least educate patients about if that does happen there. So someone's asking which drug leads to weight loss. All of the incretinmimetics. So all the glutides that I mentioned, like exenatide, liraglutide, dulaglutide, all those cause the weight loss there. Those are the biggest ones. Metformin will cause some weight loss as well, right? And then the incretinmimetic cause the greatest weight loss. Someone said, so if patients fail on metformin, then incretin is an add-on to it, or would you stop metformin and give incretins only? Let's talk about that in a few minutes. Let's get to the drug classes, and I'll show you a slide that kind of goes over how we will mix and match these drugs depending on kind of the situation. We can talk about that more in detail. And you can see here just as a slide, just to give you some ideas of how synergistic these meds can be together. So for instance, if you look at the effects of, say, sitagliptin or metformin alone, and looking at their drops in A1C, you get 0.8, 1%. It's a decent drop, but if you start to add the two together, you can start to see that synergism there. We get better response by adding the two together. So again, that's why you see a lot of combo meds. That's why you see a lot of these being used together to help out with compliance sake. And again, it'd be nice if you could just do lifestyle modifications and maybe some metformin to get your patient's diabetes under control. Oftentimes it does require more than that. So just something to note there. In terms of comparisons between the GLP-1 agonist or the incretinmimetics and the DPP-4 inhibitors, you can see here they both do well to increase insulin secretion. They can both reduce glucagon, and they also are going to help to reduce that postprandial hyperglycemia, which makes sense because you're getting less glucagon and more insulin there. Note that the weight loss that is due to things like gastric emptying, satiety, and all of that is going to be more related to the GLP-1 agonist, which also means you're going to get more vomiting, nausea, appetite suppression, and weight loss. Those you don't really see with the DPP-4 inhibitors. As I mentioned, GLP-1s have to be injected because they're proteins. DPP-4 inhibitors are not. And then in terms of safety, kind of the unique side effects would be something like pancreatitis with the GLP-1 agonist versus something like Stevens-Johnson. So just some ways to kind of differentiate the two classes there just for your sort of education. Someone said, which run more risk of reactions, the incretins or DPP-4 inhibitors? You're talking about like allergic reactions. If that's the case, then I would say more so the incretinmimetics, because those are protein based. You're more likely to see that. But again, usually fairly safe for the most part. I've never seen someone anaphylaxis, but I'm sure at least one person has while receiving that. Sorry, did you say DPP-4 inhibitors break down GLP-1 or prevent the breakdown? They prevent the breakdown, right? They're inhibiting the enzyme dipeptidylpeptidase 4, which is normally responsible for breaking down GLP-1. By inhibiting that enzyme, you're going to see less GLP-1 metabolism, so more of it sticking around, basically. Right. And then the last class we're going to be talking about here is our sodium glucose co-transporter 2 inhibitors, which is a bit of a mouthful, but these are the SGLT2 inhibitors. And so basically, if you kind of go back to your normal renal physiology, you know that a lot of things get filtered through the glomerulus that then get reabsorbed at the proximal convoluted tubules. And glucose is one of those things, right? And we know that, diabetic patients, if they have just too much glucose, it's possible to overwhelm those transporters. And then that's why you can see sugar in the urine, right? That's one of the things you can check on a urinalysis to see, okay, is there sugar present here? That sort of indicates that the kidneys are overwhelmed and cannot reabsorb all of that glucose. Well, what if we could sort of go in, it looks like I'm kind of, yeah. So what if we could go in and cause that process to be inhibited, that reabsorption process to be inhibited ourselves, right? We could actually use a drug to block reabsorption of glucose, and then you just pee all of it out. That'd be one way to get rid of the sugar, right? Is if you're just urinating it out. So we have the drugs here, and these are like kind of like the worst names, I think, to say because they sound just kind of bad rolling off the tongue. They have canagliflozin, you have dapagliflozin, and empagliflozin. Again, I think the brand names are a little bit more eloquent when you say Invokana or Fija. But anyway, so these basically are blocking those transporters. You prevent the reuptake of glucose in the proximal tubule, and then you just pee it out, right? So not only does this help to reduce blood glucose, but because that sugar is not being stored, say, in the adipose tissue, to be turned into fat, it can actually reduce body weight as well. So now we see kind of a third class of drugs that can help reduce body weight. Again, this is sort of the newest bunch of the group here. Okay, yes, someone's answering there on the board. So in terms of adverse reactions, this is kind of directly related to the actions of the drugs here. So it makes sense that, bacteria and fungus and things like that, they love sugar. They love it just like we do. And so if you have all this extra sugar coming out in the urine, it makes sense that UTIs are a risk. And this includes things like fungal infections. So urinary tract fungal infections, not super common that you would run into that. Certainly you may see it in diabetic patients, but this ups the risk of that pretty significantly. So about 10% of patients may develop that. Not only that, but you can develop some hypotension because you're not really maybe able to regulate intravascular blood volume quite as well because you're losing some of that osmotic sugar there. And then you can see things like raising serum potassium, decreased kidney function as a result of this. So this probably is not going to be a good set of drugs for patients like renal instability, I would say. Interestingly enough, you can also find that canagliflozin itself has been sort of linked to bone resorption issues and bone fracture risk. So that would be something you definitely want to avoid in someone you were concerned about something like osteoporosis for sure. And then they also can run a risk for diabetic ketoacidosis, but interestingly enough, this is a euglycemic ketoacidosis where basically they're peeing out all the sugar, then I guess their cells are not able to utilize or are not able to get enough sugar, and they end up going into a ketoacidotic state. And so you can see that rarely, but again, it's kind of an interesting thing you wouldn't expect to see in a type 2 diabetic patient for sure. So I think there's like a recent warning for like Fournier's gangrene with this. So it's a kind of an interesting set of drugs there in terms of how they work. But especially if anyone with like, recurrent UTIs or something like that, probably not going to be a good set of drugs for them. So this is a really handy slide, I think, that goes over some of the deciding factors for why you might choose one drug versus another. So you can see here the drug name. You'll have the efficacy of reducing HbA1c, is again our good marker for about 3 months or so of their reduction in sugars. We'll see the risk for hypoglycemia, which is important from a safety standpoint. Look at their effects on weight, their side effects that are sort of most notable, and then the costs associated with them. So if you look here, metformin is really good at dropping A1C, has a low risk of hypoglycemia, has neutral to weight loss. It, of course, we talked about the renal issues you can see with lactic acidosis, and then low cost. Makes sense. It's a pretty good drug to start out with, and that's generally why we start with that one first, probably along with all of your lifestyle modifications that you can do there. So then the question is, well, okay, what if metformin's not working well enough on its own? If they absolutely cannot take metformin for whatever reason, maybe it's due to renal dysfunction, maybe it's due to intolerable side effects, then yeah, you can get rid of it. But otherwise, you probably should go ahead and keep it on board if they can tolerate it because of the additional benefits that you're going to get, because it just makes insulin work better. So it makes sense to keep it on as a backbone of the regimen, because if you're using it with like a sulfonylurea that increases insulin levels, well, now that insulin can also be more effective because of the metformin. So it makes sense to use the two together, right? So again, you can kind of compare and contrast to see, okay, which ones am I really thinking might be a good option for my patient there? So maybe if I had someone who had like good insurance and it could afford more expensive medications and they were overweight, well, maybe a GLP-1 agonist would be a really good option there. Maybe you could use something like liraglutide, right? If I had someone who is at risk for osteoporosis, maybe I don't want to use something like an SGLT2 inhibitor, right? So this is, why test questions can be really kind of a fruitful trove, if you will, of different scenarios that I could conjure up on the test to say, okay, you have this type of patient, these are their past medical conditions, which of these drugs would you want to add on to metformin? Right? Which would be the next best option for this patient. And, if I said something like they're overweight, then maybe something like sulfonylurea is not going to be the best option, right? Because we know that's going to cause weight gain, right? Or if I say they have CHF, then you know something like a TZD, like Rosie or pioglitazone, probably not a good option for them. So those are the kind of things I want you to focus on, and we'll see as options there. And we'll cover this in the review as well. So you can go back to that and review the slide, and I think it will provide you some good information. At that point, then you could also consider triple therapy. So again, how you mix and match these is really up to you in terms of what you're going to be using. If by the time you need a third drug, this is when you can start considering adding on insulin. More often than not, they're probably going to be on just like a long-acting insulin throughout the day. So something like an insulin degludec or Detamir, Glargine, something like that. And then if they still are not able to get things under control, at that point you may consider doing basal plus bolus mealtime insulin, or a GLP-1 receptor agonist, things like that. At this point, though, it's going to be pretty complicated just because they still haven't gotten under control with 3 meds. There may be some other things going on, and this is why your endocrinology, coworkers can be so helpful. Your dietary, diabetic educators, things like that, can be very, very helpful from that standpoint. Okay, so someone has some questions. So someone says, how does SGLT2 cause DKA? Probably has something with their ability for the cell, because it makes sense if you think about it. Like if you're utilizing things like GLUT transporters to reuptake glucose from the renal tubules, then maybe it has some cross-reactivity with some of the GLUT transporters on the peripheral tissues. And so if you block glucose uptake there in those peripheral cells, then the cell's got to use something for energy, and that's when it starts to convert over things like fatty acids and starts to produce ketone bodies, and that's where you get the diabetic ketoacidosis. Again, not super common, but you can see the potential for that happening there, and it has at least been reported. Someone said, would you refrain from combining a drug like SGLT2s with something that also increases urine output like Lasix or spironolactone? You could see an issue with that, because remember, you have all that extra glucose in the urine that's osmotic. It's drawing water along with it. So that's why there's that risk for dehydration that you can see to go along with that, and hypotension. So if they were already on something like Lasix or HCTZ or spironolactone, that would be something I would certainly be concerned about, something I would watch for. If it's something like they're just on low dose HCTZ for blood pressure, then maybe that's not going to be as big of an issue as if they were on 40 Lasix 4 times a day for heart failure. That'd be a much different story there, and something I'd be a little bit more concerned about. So that would be more of on a case by case basis. Just to clarify, 3 classes of drugs with the biggest association with weight loss are metformin, incretins, and SGLT2 inhibitors. I'd probably, and again, I have not seen how much weight loss is commonly associated with the SGLT2 inhibitors. I'd probably say, though, just based off of mechanism, the incretins are going to be sort of the best at dropping weight, followed by the SGLT2 inhibitors, followed by metformin. I'd probably put in that rank order. I wouldn't ask you on a test which one would cause the most weight loss, but I would at least know which ones are associated with weight gain, which ones are associated with weight loss. Obviously, insulin, sulfonylureas, those are going to be the biggest ones that are going to be causing weight gain for the most part. These 3 categories here, though, are going to be the ones that are most likely to cause weight loss. Okay, other ones are going to be sort of neutral, if anything, depending on the situation. All right. So, I guess that's some good questions on that. Let me know if you have any more. Otherwise, I will continue on with our talk here. Next off, now we have just kind of like a smattering of a few different topics here that we're going to hit on that fall under that endocrinology sort of umbrella there. Some of these things sort of get lumped into other categories too. So, for instance, I think we talk about more of the actually, I don't remember if we talk about androgens here or more in the urology section, but some of that stuff will crop up here and there as we're going to see. Just real briefly here with hyperprolactinemia, this is something that is frequently seen with things like prolactin secreting tumors for sure. But remember, there are drugs that can cause this as well. So things like our dopamine antagonists, so things like our antipsychotic drugs can block those dopamine receptors, and that causes a uptick in prolactin secretion, as you'll see there, which can again lead to things like galactorrhea, amenorrhea, infertility issues, gynecomastia in male patients. But because, especially with female patients who are maybe interested in becoming pregnant, having high prolactin levels sort of puts the body in a state where it thinks that it's nursing a young one. So it says, well, I don't need to get pregnant right now. So it's part of that thought of that sort of quote unquote natural birth control. Not that it's foolproof, but for some people, high prolactin levels will make it very difficult for them to become pregnant again. So one of the ways you can actually try to help with that is if they have high prolactin levels, you can give them a dopamine agonist. So here we have a couple of ergots that we could administer. So things like bromocriptine or Parlodel. Of course, we've seen this come up before when we were talking about dopamine agonists that you could use for Parkinson's as an example, but here we can use it as an ovulation inductor in patients with hyperprolactinemia. Basically, activating those dopamine receptors would drop down the prolactin levels and hopefully allow for that patient to become pregnant if that is what they're interested in. And then cabergoline might be a different one that has a little bit higher affinity for the dopamine receptors there. And again, blood pressure is always going to be something you want to watch out for with these drugs. We saw that orthostatic hypotension is a risk anytime you're kind of messing with dopamine, because that can have effect on the blood vessels and things like that. So those would be the biggest things I would be concerned about for that. But these can be used specifically for patients with hyperprolactinemia. Now let's talk about the androgens real quick. If I just looked ahead 2 slides, I would have known what I was talking about. But so we talked a lot about the estrogens in the OB-GYN section. Now we're going to talk about kind of the other side of that, going to be the androgens, right? And so just one of the things that some students get caught up with is when I say androgenic versus adrenergic. It can be a little difficult to parse there, especially if I'm talking a little fast. Androgenic means androgen, so this is going to be like the masculinizing sort of hormones. When I say adrenergic, that is referring to things like norepi, epinephrine, things that are mimicking the sympathetic nervous system, basically. So here we're going to talk about our androgenic hormones here. And if you recall, we saw that there's a lot of interplay between these various hormones here. Of course, they all come from the precursor cholesterol and then eventually get turned into things like cortisol, aldosterone, progesterone, and then testosterone itself is going to be a derivative of things like progesterone and can be converted via aromatase, if you recall, into estradiol, right? So we're going to see that testosterone is not going to be the only androgen we're going to talk about today, but it is going to be a popular one that is used pretty frequently. So this is the most important androgen that is actually made itself in the testes, but it is not actually the most potent androgen that is found in the body. You make about 8 milligrams a day, depending on the patient, obviously. But the interesting thing is that a lot of the testosterone gets converted over into a product called DHT, or dihydrotestosterone, and this is via an enzyme called 5-alpha reductase, and this is actually the most active component, and this will become important again when we talk about things like benign prostatic hyperplasia coming up a little bit later in urology. But you want to remember that 5-alpha reductase is an important enzyme, because if you cannot convert testosterone over into DHT, you're going to get a lot less of the androgenic effects, right? You're going to be sort of, not to use not to make a pun, but you're going to kind of neuter the activities of testosterone because you cannot convert it over into DHT. Kaylee was asking, just to clarify, dopamine is inversely proportional to prolactin, which allows a patient to ovulate. I'm a tad behind. Yeah, no problem. Yes, so a patient who has high prolactin levels, if you activate dopamine receptors, that tends to drop down your prolactin levels. So it's sort of like that seesaw, sort of like what we saw with Parkinson's and acetylcholine. If you have patients with Parkinson's losing dopamine, they'll have an increase in the amount of acetylcholine that is expressed, and that's what causes tremors. Here, in this way, we see that having too much prolactin will drop down your levels of dopamine. And so in order to counteract that by giving more dopamine, giving a dopamine agonist like bromocriptine, you can then drop those prolactin levels and then hopefully allow for the patient to ovulate. The body will think, okay, now it's time I'm able to have a child now, or to conceive, right? Anyway, so DHT is important. 5-alpha reductase is important. We'll see that also some of that testosterone does get converted over into estradiol. Like, guys still produce some amount of estrogen, and that's via the enzyme aromatase, which we talked about pretty extensively. And if you recall, when we talked about that with OB-GYN, remember that if you fail to convert that over by using something like an aromatase inhibitor, we saw that a lot of patients would have more masculinizing effects, because basically they have extra testosterone that's not being converted over into DHT, right? Anyway, so again, these are metabolized in the liver just like estrogen is, and you're going to find that, especially with the oral dosage forms, this is going to be a major problem. You'll see with the androgens, they can be pretty rough on the liver when taken orally there. And they work the same way as estrogens and every other hormone that we've seen, every steroid we've seen, where they get down into the site of the nucleus. It can then cause changes in transcription factors and whatnot, which leads to the masculinizing effects, right? So, male pattern baldness or development of the testes, things like that are all related to their ability to interact with those testosterone receptors at the site of the nucleus. So, and this actually follows the same exact HPA axis that we sort of like an HPA axis, but instead of the adrenal gland, will be the gonads here. But basically, it follows the same sort of pattern as what we saw with the ovaries, right? So you have the hypothalamus releasing gonadotropin, releasing hormone that then stimulates the pituitary to release LH and FSH, which then stimulate the testes to produce testosterone and sperm. And so you can see that if you have, once that testosterone is in high enough levels, that will then feed back and shut down production of GnRH and LH and FSH. Inhibin is also something that's produced, which we're not going to talk too much about here, but that can also feed back and stop the production from the pituitary gland level. Okay, and this is why a lot of times you're going to see that when patients are taking exogenous testosterone, say for instance, someone is taking a testosterone exogenously for say like bodybuilding purposes. That's always what I think about is think about that, like the documentary, like Pumping Iron and stuff like that. But a lot of those patients were taking performance-enhancing androgens, and basically a lot of that was leading to things like testicular atrophy, and it was leading to things like infertility because of the fact that all this testosterone feeds back and stops the production of LH and FSH, which basically shuts down sperm production. The testes say, hey, we have enough androgens around here. I don't need to produce anything, so they tend to atrophy. So you can start to see where some of the side effects that you might expect from things, some of the side effects you expect to see from things like performance-enhancing drugs like androgens can come about from this. So it's pretty fascinating stuff, trying to modify sort of the natural state of things by introducing things like estrogens and androgens and whatnot. Now, we think about in terms of like the drugs that we can administer. There's certainly a wide variety that are here. I'm not going to be getting into all of the sort of illicit ones you may see being used for performance enhancing purposes. But just testosterone itself can be administered, and so you'll find a lot of different varieties here. These are just some examples of the various and numerous brand names that you're going to run into. A lot of these are either going to be things like transdermal gels that you can apply, so like Androgel. A lot of these are going to be depot shots that you can administer that are like in an oil base you can put into the muscle that will slowly release it over time, just like you would see like a depot Provera shot for a progesterone. Same thing you would see there in terms of the dosage form. So wide variety that are out there. And again, this testosterone acts just like our own natural testosterone does. Gets converted to DHT, interacts with the same receptors. The mechanism is identical, right? Again, dihydrotestosterone itself is only produced from testosterone due to that enzyme 5-alpha reductase, right? Getting into some of the synthetic varieties here, you can see that mainly they're taking testosterone derivatives by either adding on an ester group or alkylating or making some slight variation on the product there. So for instance, you have things like methyl testosterone, which makes sense. You just pop a methyl group on there, fluoxymethostrone, oxandrolone. You'll find that the PO products are not often recommended, and we'll see why in just a second. But a lot of it has to do with the heavy hepatotoxicity, the heavy toll on the liver that these steroids can take, as we'll see. So, as I mentioned, testosterone itself can have some effects. So we'll see things like increase in growth of skeletal muscle. We'll see things like erythropoiesis, development of internal genitalia. Whereas DHT is where you're going to see a lot of effects on things like external genitalia and also effects on the hair follicles. So DHT is a big reason why you see things like male pattern baldness that can develop there. And then as some of that testosterone gets converted over into estrogen via aromatase, that's where you can see things like effects on the libido. You can see things like closure of the growth plates on the bones. All that's related more through the estrogen sort of effects there. So what are some uses of our androgens and anti-androgens? Well, basically for androgens, we can try to replace maybe what some patients are missing, maybe due to things like male infertility. If patients are having osteoporosis, we'll find that androgens like testosterone have positive effects on the bones, right? MT here just means methyl testosterone. So again, the oral variety that you could take potentially. In some cases, you may find some patients taking this in combo with estrogens. This is not super common. I'm not 100% certain how often that actually happens there. And in some cases, you may actually find it can be used for certain cases like inoperable breast cancer. Again, that's probably pretty rare since nowadays we have a lot stronger aromatase inhibitors and serums and things like that. And actually, a really interesting case where you can use it could be for patients who are experiencing like muscle wasting or just chronic wasting due to chronic illness, basically. So things like AIDS, after burns or trauma. This helps these patients to put weight back on basically by helping to utilize the anabolic effects of the androgens there to put muscle mass back on and things like that. John's asking, how can androgens cause infertility, but they can be used in cases of male infertility as well? So a lot of it has to do with it gets a little bit complicated. It kind of goes back to when we were talking about like the GnRH agonists there, how they can both be used to sort of kick off ovulation, but they can also be used to kind of shut that whole process down as well, depending on how much we're sort of like activating those receptors there. But this would be more in cases for men who aren't producing enough on their own, as opposed to men who could normally be producing enough to be fertile, but then if they're taking sort of exogenous amounts in over the normal amount they would normally produce, that will then shut that whole process down. So this is more like kind of replacing what they're missing to sort of get back to like their baseline level, what they should be producing. To get more detailed than that, probably have to do some more research, but that's sometimes how we can see that being used for the most part. Oftentimes I see more often things like, GnRH agonists can be also used as well to help kind of stimulate that whole axis into action there a little bit additionally. In terms of anti-androgens, we'll see here that a lot of times this is going to be for things like metastatic prostate cancer, where you can see this is going to be useful because the prostate really does respond and grows as a result of the effects of DHT and a testosterone. And then we can also see things like hirsutism, which may be caused in females who are experiencing too much hair growth. And hirsutism may be due to excessive androgens that they're producing. This can help to blunt that. So there's some cases for both androgens and anti-androgens to be used here. As I mentioned, the oral formulations are typically metabolized pretty readily in the liver, so things like just regular old testosterone really wouldn't be useful orally because it just get, the bioavailability would just be too low through the oral route there. So that's why they end up providing things like alkylated or methylated forms, and that will allow for it to be able to cross through and have some bioavailability. But again, those tend to be pretty rough on the liver. And then we'll see that the injectable forms are typically going to be like testosterone in some sort of oil base. Now, you never want to use any kind of oil-based product in the veins, mainly because oil and water don't really mix all that well, and it can actually cause emboli. However, you can see here that by using it in the muscle, it allows it to kind of slowly leach the drug into the bloodstream. Here's just a variety of different ester salts that you're going to find the testosterone in, and they'll have different brand names that are associated with them. I'm not really going to get too persnickety about you being able to differentiate between those. Just know why we might use an intramuscular form of testosterone, why we use it in an oil base, but it allows for slow absorption of that over the course of months. And then pretty popular, I do see a lot of transdermal testosterone, things like Testoderm, Androgerm, you find gels, foams, patches, all kinds of things you can. In terms of anti-androgens, there's a couple of different ways we can do this. So one of which is going to be an androgen receptor antagonist. So we have two here, flutamide and bicalutamide. We'll have mixed androgen receptor mineralocorticoid receptor antagonists. That's where we have our spironolactone, which I know we've talked about before. Remember how in patients who typically express a lot more estrogen, so typically female patients, how spironolactone can cause masculinizing effects. And then because they have relatively low resting levels of testosterone, but for male patients who normally produce a lot of testosterone, having a partial agonist on those androgen receptors causes more feminizing effects. So now you're dropping their overall activity of androgens down. So spironolactone can have sort of the opposite effect opposite to whatever the patient would normally be expressing in the highest amounts, whether it be estrogen or androgens. Another example here would be sort of a mix, sort of progestin receptor agonist, androgen receptor antagonist, so cytoproterone. And then probably most popular, which I see a lot for things like BPH, are going to be our 5-alpha reductase inhibitors, things like finasteride and dutasteride, which we'll see here in just a little bit. Again, those block the conversion of testosterone over into DHT, and DHT is the more sort of strongly androgenic compound than testosterone is itself. So what are some of the side effects of androgens? Why are they a problem? One of which is that they're going to stimulate the prostate to grow, which means they can cause impingement on the urethra, lead to things like BPH or potentially even prostate cancer. So that's one thing to think about. They cause infertility and testicular atrophy, just like I mentioned before, because they will basically activate the negative feedback loop at the level of the hypothalamus and the pituitary. So basically shut down LH and FSH production. You can see some gynecomastia and acne. Again, you're thinking like, why would it cause gynecomastia? That actually has to do with having that extra testosterone around being converted into estrogen through the activity of aromatase. So sometimes what you'll see is, especially patients who are taking, I think I've seen this like on like bodybuilding sites and stuff like that, where they'll talk about like their regimens of utilizing performance enhancing drugs, and they talk about utilizing aromatase inhibitors along with testosterone based products in order to prevent that conversion of it over into estrogen. It helps to limit some of that gynecomastia that they can develop there. Kelly's saying there was a seminar the other day. The lecturer mentioned some trans patients taking spironolactone for that reason, which is pretty interesting. Yeah, and actually, I don't know if how many of you guys are on Reddit or not, but there's always some really interesting, like I see some of these like progress pictures of people who are transitioning, and I remember seeing one. It was like very it was a male to female trans patient. I guess not patient, they're just a person on the internet, but they posted their before and after pictures, and it was really interesting because they talked about being put on Proscar, which is one of the 5-alpha reductase inhibitors, and it was funny because like their hair was like pretty like thin and stringy beforehand, and then the after picture they had this like just luscious hair, and it was a lot of it because they weren't producing as much DHT as a result of the aromatase inhibitor, or not the 5-alpha reductase inhibitor. So they had less DHT, and so now they were losing a lot of that male pattern baldness that they had, and they were developing more hair growth. So it was pretty interesting to see there. Very interesting stuff, I think, with like trans patients, and I'm always interested to learn more about that stuff for sure. Other things we're going to see here is that you will see erythrocytosis. Typically, if you're taking this to replace what is maybe missing due to low levels, you shouldn't really see too big of an effect on the hemoglobin hematocrit, but you may see some bump there, especially if you have patients who are like chronic, like with like wasting conditions, like some patients with AIDS, cancer, things like that. Having anemia could be one of the effects of that. So by taking testosterone, that may help out for those patients. You may see a little bit of a bump there in terms of their hemoglobin hematocrit. Because testosterone will still have some androgen receptor activity, you will find that it can cause sodium and water retention. So this may be bad for patients with CHF. You may find a little bit of extra edema develop there. And then really the big thing is why you don't see a lot of oral androgen use is due to the hepatic effects. So you can see things like cholestasis. You can see changes in the lipid profile, hepatitis that can develop with this. That's why a lot of times you'll see patients using like injectable forms of testosterone or other androgen products there, because it helps to mitigate that, because it skips the liver when you're using it in a parenteral form there. And of course, you can find masculinization of women, which may be a good thing, right? So it depends on the patient and what they're particularly using their androgens for. So look at hormonal therapies to try to treat benign prostatic hyperplasia. We'll get into more of this when we get into the urology section later on. But this is the primary place you're going to see your DHT inhibitors. Basically, by blocking the activity of 5-alpha reductase, you'll prevent production of DHT. And so we have two here. We have finasteride and dutasteride. Interesting, one of the things you want to be really careful with, and this is something we have to practice in the pharmacy, is that these can be really teratogenic, which makes sense because we know that like giving estrogens during pregnancy is not a good idea because it can affect the fetus. This can really affect the fetus too, like that whatever the developing fetus is may need that DHT to help with its normal production, and so actually this is considered a hazardous drug. These two here, we don't even let really any of our coworkers, but especially like women of childbearing potential, even handle this stuff without gloves because of the fact that if they were to have exposure to it, potentially then they could have untoward effects to a fetus there. So those you gotta be really careful with in terms of pregnancy. Other things you could use as well include GnRH analogs. Basically, these are things that will help to simulate the effects of GnRH, where having a little bit can be good to help stimulate the process, stimulate the whole axis. Having too much of it tends to shut it down. And we talked about that before a little bit in the OB-GYN section. That included goserelin and leuprolide here. And again, you can kind of see how they're going to be kicking in, whereas with the GnRH antagonist can either be sort of positive or negative here in terms of their overall effects. A lot of that depends on the dose in which they're getting, and then certainly can see where things like flutamide, spironolactone can have anti-androgen receptor activity here, whereas things like finasteride are going to inhibit the 5-alpha reductase enzyme. So you can see different steps along the pathway to how we can reduce overall testosterone and androgen receptor activity. Okay, that's it for that section there. Moving on. Someone said, when would it ever be indicated to use DHT inhibitors in a female? Not really familiar with that necessarily of any particular cases. I'm trying to think of any off the top of my head. If there were maybe like in a hyper, androgenic sort of state, but that wouldn't be an often thing there. But when I'm talking about it like from a pharmacy perspective and more like in a healthcare environment perspective, is talking about how even, even scant exposure to these drugs here can be potential exposures for the healthcare providers, right? So that's why it's really important to use proper PPE when handling certain drugs. And this is just one example of that. So for instance, if you have a patient who's receiving chemotherapy, it's not just the drug itself that can be hazardous to the patient, it can be hazardous to the healthcare workers too. So say for instance, if someone gets a needle stick, or if someone's handling, say, a dirty diaper from a kid who just got, from say an infant or someone that just got chemotherapy, that diaper could still be contaminated with hazardous materials that could affect the nurses that are handling that if they don't have good PPE. So just something you'll may encounter occasionally with certain high risk medications there. Let's see. Isabel's asking, is that why Propecia is used for male hair loss? Yeah, that could be is one reason you can use that, because it will help to limit the effects of DHT, which cause that typical male pattern baldness there. But again, you got to think about the other side effects you could run into, where you're having less DHT activity may lead to more feminizing sort of effects there too. So it can be a little bit of a double-edged sword depending on your patient. Oh yeah, so Shelby's asking, can you explain how spironolactone is different for females taking it? Please, I got lost. No problem. So let me try drawing it out. So let's say if we have, if you were looking at like overall testosterone levels here, so we're looking at T levels for a patient, and let's say that we'll use blue for the male patient here. So if you were to typically see a normal like male patient, you see the testosterone level be pretty high, and just because we're being gender normative, I guess, we're going to use pink here for the females, and their overall testosterone level should be relatively low, right? Let's say we gave them spironolactone, which would be a partial agonist at the androgen receptors. Overall, what you would see, and then say spironolactone is going to put them at a level right here in the middle, right? So it's going to drop them down or bring them up to basically the set point because you're having partial agonism at those receptors. So whereas with the male patients, they normally have full androgen receptor activity because they have testosterone and DHT just hitting it at 100%. When I start to introduce something that is now occupying some of those receptors and giving you less activity, maybe only like 75 or 50%, now all of a sudden you're going to see that the overall androgen level activity is going to go down because those spironolactone receptors are now being or the androgen receptors are being occupied by spironolactone, which is only a partial agonist. So you're going to see overall they have lesser testosterone activity than they did before, right? Whereas with a female patient, where they have relatively low resting testosterone levels, by giving them something that is now partially activating those androgen receptors, so now they're going up from relatively low activity, like say 10% up to 50%, and again, I'm just making up numbers here, then you'd see that overall their androgen receptor activity is going to be going up. So you can see for female patients, they would get more testosterone effects, and for male patients, they get less testosterone effects. So hopefully that makes some sense of how you can see sort of the opposite actions in those patients there. Kate's saying, is that why it is given to women PCOS? Because they have too much testosterone anyway. Yeah, that could be one reason why, is because by giving spironolactone, they're going to get less androgen receptor activity, and that will help to reduce that down and hopefully, have them get back to more of their normal kind of baseline state there. Yeah, I always struggle with ways to explain that better to students, and this might be one of the better ways I've come up with, perhaps. You can always let me know in my evals and say, your drawing is terrible, but maybe I got something away from that. I don't know. Anyway, let's talk about the adrenal glands now for a short time. We've talked about corticosteroids probably ad nauseum at this point here, but of course they work just the same as our estrogens and our androgens, and working at the site of the nucleus. Of course, we know there's our glucocorticoid receptors, which are responsible for things like glucose homeostasis, for things like affecting, responding during times of stress, cortisol being the main thing activating those. And then we have our mineralic corticoid receptors, where aldosterone is our primary player there, affecting things like blood pressure, affecting things like sodium and potassium homeostasis, Of course, we know that works more in the distal convoluted tubule, right? It helps to suck in sodium and hold on to that at the expense of potassium. But cortisol here, or basically hydrocortisone, when you see a tube of hydrocortisone cream, that's basically the same cortisol that we produce ourselves. And you'll find that we produce maybe 10 to 20 milligrams daily. However, that can change pretty greatly. So it actually follows more of a circadian rhythm, so it can change during different times of the day. It also will increase during stress states. So for instance, on a Monday morning, when you may have a farm test coming up, perhaps you'll be secreting a whole lot more than you will, say, for instance, an hour and a half later when you're done with the test, right? So certainly this is going to be quite different. But that actually is important too, because when patients become physically stressed, if they cannot make enough of their own cortisol, that can lead to some problems. We're going to see some adrenal insufficiencies that can develop here. So just as an example, a sort of chronic insufficiency like Addison's disease, it makes sense of some of the issues they're going to run into because they're lacking both mineralocorticoid effects and glucocorticoid effects, right? So you can see things like weakness, fatigue, hypotension, weight loss. Kind of makes sense because you kind of see the opposite effects when someone is on corticosteroids, right? You're going to see hypertension because they're holding on to more water. You can see weight gain. You can see increased sort of, anxiety or just, kind of overall kind of, kind of get a little bit angrier sort of or agitated in some cases there. And they can't really maintain their glucose super well if they're deficient in these corticosteroids. And so one of the big problems that they can run into is if all of a sudden they get into a really stressed state where normally their body would be secreting a lot of these corticosteroids, you will find they can develop insufficiency. And now they cannot regulate their blood pressure effectively, and they can develop really severe hypotension and death potentially. And so I remember we had one patient who would frequently come into the ER who had a pituitary tumor removed, so they were having to replace a lot of the hormones that they could not produce on their own. But one of the big problems they ran into was they couldn't produce enough ACTH. So they would have to take exogenous steroids, things like hydrocortisone. And oftentimes they would get very sick. They would develop a insufficiency, and then their blood pressure would just tank. And so they had to come into us to get replacement corticosteroids. They would get their hydrocortisone. They would get lots of fluids. And they would also get this other drug called fludrocortisone. And this is actually a salt-retaining hormone. This is actually a drug that just purely works on the aldosterone receptors to try to hold on to fluid in the vessels, draws that salt and that water in to try to increase blood volume. And so that's one thing you'll see there occasionally. Typically, we like to avoid like non-salt retaining ones because the blood pressure issue here is the thing we're most concerned with there. JFK must have been chugging hydrocortisone. He likely was, and again too, you'll see a lot. No, didn't he have hyperaldosteronism? I don't remember what he had specifically. Anyway, someone said I've become numb to the Monday mornings before a farm exam, rolling with the punches at this point. Well, that's good. I'm glad you've become stronger as a result of constant pressure. You know what they say? Constant pressure produces diamonds. That's what all of you are to me right now, right? Moving on, let's talk about thyroid pharmacology. Something like that. You sound not so convinced. Anyway, so thyroid pharmacology here. Let's talk about the thyroid. This is a very important thing because you're going to see this present to you all the time, and so many other things can be sort of wearing them, or I guess hypothyroidism and hyperthyroidism can kind of be looking like a lot of other things. And so this is why it's always one of those things you want to check on, because you don't want this to be like the big obvious thing that you didn't look at and that could be fixed pretty easily, as we're going to see in a lot of cases here. And again, we're going to find that either hypersecretion or hyposecretion can be a result of a lot of different levels, right? So it could be an issue of like maybe you're having issues in the hypothalamus, maybe you're having issues in the pituitary, or a issue at the site of the actual, actual thyroid gland itself. Obviously, if they're having hyposecretion, if they're not producing enough thyroid hormone, we're just going to replace that. We can just give them what they're missing, and then you're good to go, right? So you may be doing this for patients who are naturally not producing enough of their own thyroid hormone. Maybe they've had a thyroidectomy. This is where we can replace it. For hypersecretory issues, again, it can happen at any one of those three levels there, and we're going to find a couple ways we can help to treat that as well as we get into it here. Anyway, so again, you can see the axis here, where, and again, it looks very similar to what we saw with both the HPA axis. It looks the same as what you would see with the testosterone production, things like that. But basically, the hypothalamus is going to be signaling with TRH to signal the anterior pituitary to produce TSH. TSH is then going to stimulate the thyroid gland to release T3 and T4, right? T3 and T4 are the main thyroid hormones we're going to be focusing on today. And I'm sure you know this, but T3 being the more active form, T4 being sort of a more kind of a, I think it's more of like a reserve kind of form until it gets converted over into T3 in the peripheral. But anyway, and again, you can see how these will feed back and stop this process here, which is why a lot of patients who have hypothyroidism, you'll know that they'll have a high TSH level because basically they lack the T3 or T4 to shut this whole process down, right? Another big player here is going to be iodine. That's an I minus here. This is going to be important both as it can help to stimulate thyroid hormone production, or it can actually help to inhibit it, interestingly enough, as we'll see. One of those things where having too much of a good thing tends to shut things down. Having just the right amount is good for us. But basically, if you look, and I like this picture here, kind of makes it pretty straightforward in terms of how all this is working here. And I'll show you a slide that kind of talks through it more specifically. But basically, you're going to have the follicular cells here in the thyroid hormone. Here we're going to have the apical side. Here we're going to have the basolateral side. And basically, you're going to see here that iodine is going to be coming in. And again, I'm going to confuse iodide and iodine. I always do it every single time, and I keep telling myself I'm going to get it figured out the next time I teach this, and I never do. But anyway, you're going to have iodide coming in here, and that's going to get converted over where it can be eventually undergo this process called organification. That's going to basically combine tyrosine plus thyroglobulin. And you're going to see that's going to form one of two products, either monoiodotyrosine or diiodotyrosine. Okay. At that point, those two products can come and combine together. So if I have a mono and a diiodotyrosine come together, I get T3. If I have two diiodotyrosines coming together, I get T4. I'll show you what that looks like in just a moment there. Eventually, that is going to come back through the follicular cells. It will undergo proteolysis where it gets rid of that thyroglobulin, and then it can be released out into the bloodstream. Then it can do its thing. T3 can go ahead and interact with the nucleus to change transcription factors, cause things like your blood pressure to change, your basal metabolic rate to change, can do all that good stuff. T4 is going to be more of the inactive form. It is going to be kind of stable, just kind of floating around the bloodstream until it's needed, and then it gets converted over into T3. Okay. So again, it's going to be the iodide trapping that happens there. So basically the iodide gets brought into the follicular cells, and you're going to see it can be inhibited, especially by having too much iodide around. That can actually inhibit that process there. And then it gets iodide, will be oxidized into iodine. So that's the process. Iodide comes in to be oxidized to iodine. Again, I can barely get this correct, so I'm not going to expect you to get that right on the test either. But just know the iodide is coming into the cell, going to get converted, and eventually it's going to undergo that organification step where it's going to form mono and diiodotyrosine there. Okay. And then again, this is another step where high levels of iodine can actually block this. So again, having a little bit's good. Having too much is going to be in him. Actually, having too little is bad because you're not going to be able to produce the thyroid hormone. Having just the right amount is good because now you can produce it. Having too much iodide is going to inhibit that whole process as well. So kind of two ways you can produce hypothyroidism, but we'll look at some ways you might be able to use that to our benefit in a little bit. Anyway, so as I mentioned, that hormone formation there, once you have two molecules of a diiodotyrosine come together, they will then form T4 or thyroxine. This is going to be very important from a drug standpoint, as we'll see here in just a little bit. And then if you have one MIT plus a DIT come together, then you get T3. That is now the active form. However, you probably produce a ratio of T4 to T3 about 5-1. So even though T3 is more active, it's not producing the volume as T4 is. So again, you can kind of look back at this picture and kind of get an idea of what we're talking about through those steps here. I think more important is showing you what, I'll show you this in just a second. Anyway, so once that bound thyroid hormone crosses back across the apical membrane, it can undergo that proteolysis where it removes the thyroglobulin, and now it's free to go into the bloodstream and do its thing. Remember, T4 is a prohormone, less active. Once it gets deiodinated in the periphery, it converts to T3, and now it is active. This is another case here, high levels of iodide could affect this as well. And so, interestingly enough, you can find that the deiodination process can happen at a couple of different spots. So if you do it in the wrong spot, you end up getting something called reverse T3, which is actually inactive. So here's what this would look like. So imagine you have T4, which makes sense. You can tell it's T4 because it has 1, 2, 3, 4 iodides on it, right? And then if it undergoes the wrong process there, this is called reverse T3, and this is actually inactive. It doesn't do anything. Versus if you remove the correct iodine, now you get T3. And when I was talking about the di and monoiodotyrosines coming together, this is what I was talking about basically. You can imagine a a monoiodotyrosine coming together and popping on with a diiodo and you get T3, versus if I had two diiodotyrosines, you get this popping together to make a T4, right? That doesn't make sense, let me know, but that's the general process for how this occurs. So, getting into it, how do we replace this? How do we provide the patient maybe what they're not able to produce themselves? And so, this is what we're going to be doing for most of your patients with hypothyroidism. First off, we have our gold standard. This is levothyroxine, Synthroid, Levothyroid. Synthroid is probably the most common brand name you're going to see for that. And this is the hormone of choice here, mainly because it has pretty consistent potency and a nice prolonged duration of action. And if you think about it, though, you're like, well, if the patient's has hypothyroidism, they don't have enough T3 or T4. Why am I giving them T4? It's going to take. Why don't I just give them the active T3? You could do that, right? So we have a product like that called liothyronine, which is T3. And yes, you're correct. It would have a more rapid onset. However, for hypothyroidism, it's kind of it's a marathon, not a race. So we don't really are in no big rush to correct this right this second there, right? Typically most patients don't die of hypothyroidism. So we can go ahead and start to give them the T4 and get a much more consistent, prolonged effect, and that's going to be better overall for the patient, which is why we do this, right? Keep in mind, though, is that most of the time this is going to be orally administered. It's pretty rare circumstances you're going to see parenteral levothyroxine. And in fact, the one place I see it most often is going to be in patients who are patients of trans life. Trans life actually has to do with organ transplant. And so if you had a patient who is like certified brain dead and they were going to be able to donate their organs, a lot of times once you're brain dead, you kind of lose a lot of control over things like regulating blood pressure and glucose and things like that. So the trans life nurses would come in and they would be able to get the patient stabilized, and frequently they would give them IV levothyroxine in order to help keep their thyroid levels under check. But anyway, usually this is orally administered, and this is going to be a big one that can interact with lots of other things like calcium, iron, aluminum. So definitely separate these out from your other medications, especially multivitamins and milk and things like that, to make sure your thyroid hormone actually gets absorbed. Because you could have a patient who's on an appropriate dose, but if they're having some interaction happening here, and say they're drinking it with their coffee that has like, a ton of cream in it, they may not be able to absorb it very well, and thus they remain hypothyroid even though they're getting an appropriate dose, right? And then certain drugs that enhance the activity of CYP3A4 in particular can enhance excretion of the drug here as well. So you would want to be watchful for that. But again, most of the time you're adjusting the dose based off of their TSH levels and how that's responding, because they should go back down to normal once you get the T3 and T4 in a typical level to activate the negative feedback loop. That's what our gold standard is. As I mentioned, liothyronine would be the more active form that would kick in much more quickly. However, it doesn't really provide any overall benefit from a clinical standpoint in the long term. Costs more, has more frequent dosing. There's no point in doing it, right? You don't really get that much bang for your buck as compared to good old fashioned levothyroxine. Oh, another really interesting thing here too is, what would happen if you had like an overdose of levothyroxine? Like if I had someone call me at the poison center and say, oh my gosh, my child just had my entire bottle of levothyroxine. What do I do? You guys think I'm going to be like super concerned or like not so concerned? Although the parents might be really concerned. I'm actually not really all that concerned about it. At least today, I'm not all that concerned about it because it takes about a week for that stuff to convert over. And so I would basically tell the patient there, okay, well, you may have a little bit of GI upset today, but in a week or so, you want to go back to your PCP and go ahead and check out those levels of T3 and T4 to make sure those are not too elevated, in which in some cases we may need treatment. And that's when you start to see things like heart rate go up, blood pressure go up, things like that. You normally, sweating, anxiety, you expect to see with hyperthyroidism. But again, it takes about a week or so. It was really interesting. Again, another Reddit story, but someone was talking about their roommate, taking all their levothyroxine to lose weight. And it's like, okay, well, nothing happened. They said, okay, everything's good. They're like, no, send that patient to the doctor in a couple of days, because that could be a really big problem, once it gets converted over. Again, never take medical advice from online, especially places like Reddit and things like that, or Facebook or anywhere like that. It's usually not great. Regardless, though, there's some other compounds too that we can utilize, like Liotrix is a 4-to-1 ratio of T4 to T3. This is thought to be more of a quote-unquote sort of natural sort of ratio to what a body would naturally produce. Again, I don't know that you get any clinical benefit from this, so more expensive, not as commonly used. So I think most people are just familiar with using Synthroid, and they just stick with that. And what we use this for most often is going to be for things like Hashimoto's, mixed edema, if they have a thyroidectomy, or if they've had like a radioiodine ablation of the thyroid, maybe due to cancer or something like that. Those would be the main sources for its. So again, how does it work? Thyroid hormone is going to get down to the target cells, which again, the thyroid hormone affects a lot of cells across the body. If it is in the T4 conformation, it will get deiodinated peripherally to turn into T3. That can then enter the nucleus and then can be activating various thyroid hormone receptors. Depending on the tissue, it'll have different effects there. As I mentioned, it can affect blood pressure, metabolism, things like that. And again, it's interacting with those nuclear receptors there. So it can either turn on, turn off things like, gene transcription, can lead to a whole host of different metabolic effects you'll see. So what do I do if I have too much thyroid hormone? Like what if I have too much around? I'm developing things like thyrotoxicosis, maybe even thyroid storm is happening here. What could I do? Well, I have a couple of anti-thyroid drugs here. These fall under the thiourolines or the thioamide family, kind of two names for the same thing here. But there's two drugs in this category. There's propylthiouracil, which is more commonly known as PTU, and then there's methimazole or tapazole. Both of these can be utilized for hyperthyroidism. Probably would avoid methimazole in patients with like really severe liver disease, but for the most part, it's mainly provider preference in terms of which one they're going to be picking there. These basically are going to help to stop a lot of the steps along the production of thyroid hormones. We'll see here in just a moment. In terms of complications, really the biggest thing to watch out for it would be in the CBC, especially for patients taking this chronically, because you can see things like agranulocytosis develop there. So obviously that puts them at big risk for secondary infections. How these are going to work is basically by interfering with the oxidation of the iodine. It can also interfere with the organification step, and also will basically just decrease overall production of T3 and T4, which basically sounds good. However, if someone's experiencing like thyroid storm right now, like they're hypertensive, tachycardic, that's not going to do anything for them in the short term, right? Because it doesn't do anything to the circulating T3 or T4. It just helps to decrease further production. So this may be done for more of a chronic sort of state there. Honestly, what we do in a lot of cases as well for thyrotoxicosis is we can do things like giving them propranolol. Interestingly enough, propranolol as a beta blocker, for whatever reason, helps to decrease the conversion of T4 to T3. That can help out to decrease some of the overall actions of the amount of T3 you're producing, and thus can reduce some of the positive thyroid actions that product has there. Places where we'd use this include things like Graves' disease, where that autoimmune condition actually stimulates the thyroid gland to produce more T3 and T4. And in some cases here, we can actually utilize it if patients are having, say like cancer or something like that, if they have like a goiter, we can actually shrink the gland down, because if it's not producing as much T3 or T4, it starts to atrophy, and that makes it easier to remove if we need to do like a thyroidectomy or something like that. Some other things we could do too include radioactive iodine. This is actually kind of interesting. So by using iodide 131, this can be utilized as a therapeutic agent to help radioablate the thyroid gland. So this is actually really interesting. So basically, the ways that radiation causes problems is because it can denature cells and denature DNA, and basically just triggers apoptosis and affected cells here. What's interesting is by giving radioactive iodine to patients, it is preferentially uptaken into the thyroid gland, just concentrates there. And so when it does that, it emits things like gamma and beta particles that help to basically just destroy that thyroid gland where it's sitting there. And so you can use it for that ablation for cancer-like purposes, and can help out with in conjunction with things like surgery potentially. Now, for thyroid scans, you'd use a different variety of radioactive iodine. So you use like iodine 123 as opposed to the 131. Actually, what's really interesting too is if there was ever a nuclear blast that happened, say we lived in fallout times or something, if you were not killed by the initial blast, one of the big things you'd have to worry about in the ensuing aftermath would actually be hypothyroidism, because a lot of the common isotopes that are going to be formed after that radioactive blast is actually radioactive iodine. It's iodine 131, which will preferentially, if you breathe it, will uptake into your thyroid gland and cause hypothyroidism, right? Plus, blood pressure issues and fatigue and all that kind of stuff. So one of the things that you'll see in a lot of patients who are like, survivalists or like bug out bags and stuff is they have like iodine tablets that they'll take. So in case something like that happened, what you can basically do is try to saturate your thyroid gland with as much iodine as you can of good iodine, and then prevent the radioactive stuff, and you'll just go ahead and just eliminate it without it interacting with the thyroid gland at all. Yeah, so yeah, in Chernobyl, the TV show, which I cannot recommend enough, that was a really, really fascinating show. And I mean, just the depiction of radiation sickness and poisoning is incredible, I think. But yeah, they would give iodine tablets and helps to save the thyroid gland, basically. But you never know what could happen tomorrow. Hopefully, we don't live in Fallout times, but it could happen. In case, I would try to find some iodine tablets. They would be quite helpful if that were to occur. I haven't seen that one, Shelby, so I don't know that. Anyway, so again, how the radioactive stuff is working is basically depositing in the colloid, and that emission will kill those follicular cells there, basically. Yeah, it's like that elephant's foot. Yeah, I don't know if you've ever seen that. Just look up Chernobyl elephant's foot, and it's just like massive radioactive thing there. I loved all that information, that stuff coming out, like talking about how the actual reactor blew up and everything. Pretty wild stuff. But again, because they're getting this, you can see that delayed hypothyroidism because it takes time to kill off those cells. And again, your circulating T3 and T4 still works just fine. It's just a matter of producing new stuff is going to be inhibited there. So that's kind of the downside. So someone's asking, so how would I treat thyroid storm? So basically, you have a couple of things. One, you can treat the acute sort of metabolic effects that are happening right now. So if they're hypertensive, tachycardic, I can give them things to try to calm that down. So things like beta blockers. That's why propranolol is really good, because it also helps to prevent conversion of T4 to T3. That's a really good option there to get blood pressure and heart rate down. If they're extremely anxious, you can do things like benzos. If they're really hyperthermic, you can cool them down with like cooled IV fluids. A lot of different options you have there in terms of helping to manage that. But really, it's the cardiovascular stuff you want to fix first. And so that's why propranolol is a pretty good option there. So you may see that used for that particular purpose there. Not other, I don't think any other beta blockers have been shown to do that. Mainly it's just propranolol. Pretty cool stuff. But other things we can do too, which is actually interesting, is we could actually use, instead of trying to kill off the thyroid gland, we can actually use really concentrated forms of iodine to actually help decrease production of thyroid hormone. This is another way you could treat hyperthyroidism. And so this is something, if you ever see the term SSKI, that stands for saturated solution of potassium iodide. And there's other thing called Lugol solution, that is another potassium iodide based product there. At least housing is cheap in Chernobyl. I don't know if you guys ever seen. There's a documentary about the I think like the babushkas of Chernobyl or something like that. Like these really old ladies they're like, we're not gonna die of cancer. We're gonna die of other stuff first. We might as well still live here in our homes. But pretty wild stuff. Anyway, so you can see here you can actually use really concentrated forms of potassium iodide to give to the patient, and that will actually help to saturate the thyroid hormone or thyroid gland to help prevent production of new thyroid hormone. Right? We said too much of a good thing can stop production, and this is one of those cases there. And we can actually do this along with things like the thioamide therapy. So you can do things like propylthiouracil or methimazole plus this. It can help to reduce some of the thyrotoxic symptoms in a couple of days there. So that can be very helpful. And you'll see actually the decreased vascularity, the gland will start to shrink, and that can really help out. You can develop too much, or having too much iodide can be a problem though. You can see iodism is what they call this here, where you can actually see things like mucous membrane ulcerations. You can have salivary glands become swollen, a lot of kind of oral stuff you'll see there, and rash to go along with this. And as I mentioned, you can use that prophylactically if at risk for radiation exposure, which hopefully none of you ever will be, but if this were to occur, that's something you can. Someone said, I'm sorry I'm behind. That's okay. Is propranolol the only beta blocker you can use for hyperthyroidism? What would you use for patients with asthma? In that case, as far as I know, propranolol is the only one I've known that's been shown to do that. There might be conflicting evidence, and I'd have to rethink my position if that was the case. But classically, you really think of propranolol there. It's one of those cases where you're kind of thinking about, okay, well, this patient has a history of asthma. They're already in like a really hyperadrenergic state anyway because of this hyperthyroidism. They're already releasing a lot of like norepi and epinephrine and stuff. That's probably already dilating those bronchioles anyway. Am I going to cause a problem if I put a beta blocker on there? I don't know. But if they're already in the ER for thyroid storm, Well, I'll probably give them some albuterol too while I'm at it, right? So I can treat them through the asthma attack if that was the case there. So you probably take the good with the bad and try to look, kind of weigh your risk versus benefit. So it might be a little different in that calculation if they had asthma, but there probably is still something you could try it and at least see how the patient responds and just monitor their FEV. Anyway, other things you can see. So here's another case where you can use a contrast dye that is contains a lot of iodine in it. So iodinated contrast media. This is another thing you could use for thyroid storm as well, because not only does it help with the production of T3 and T4, but it also helps with peripheral conversion. Just like beta blockers would, like propranolol, it prevents that conversion of T4 to T3 as well. And otherwise, for that acute treatment, is pretty relatively non-toxic for the most part. But again, the biggest thing we're worried about for thyroid storm is really just that elevated temp, the cardiac overload. Those are the things we can treat with things like, antihypertensive agents, evaporative cooling, things like that can be most useful there. Anyway, that covers it for this section. Do you guys have any questions on that? I have 20 minutes left and I don't want to get too behind, so I'm going to go ahead and start the next section. Forgot my speakers are on. That's very unprofessional of me. It's just a small topic. It's just nephrology. No big. Have you started this with Professor O or Dr. O yet? Someone said, "Wow, great section." That's the first time anyone's ever said, "Wow, great section." Thank you so much. It makes me feel all warm inside. Only one lecture so far. Okay, that's good. Really enjoy endo. I think this stuff's pretty neat too. I think it's interesting how, like, even something as simple as like thyroid hormone can have such wide effects in the body. And so it's just really interesting to see how we can modify that with drugs, either both in the positive and the antagonistic sort of state there. Someone said, if a patient overdoses on levothyroxine, could you give them iopidate? Or ipodate? Generally, in that case, there I'm going to take a more watchful waiting sort of approach there, because again, it depends on how much they took, depends on how young, how healthy the patient is, things like that. I'm going to take a more of a watchful waiting sort of approach. So if it was like an elderly patient, that's maybe trying to harm themselves and a whole bunch of levothyroxine, in that case, there I'm probably going to refer them into the ER anyway, because typically with like patients who are trying to do self harm, they oftentimes don't just take one thing. And so you always have to, assume the worst case scenario. So you send them in just to rule out other ingestions that have happened there. If it's a little kid, you can be reasonably sure that, they're not going to be taking a lot of things. If it's a young kid like 4 or 5 and they got into some levothyroxine, in that case, there's probably a single ingestion, and it's probably not going to be enough for them to really get in trouble. So I usually will have them wait a few days. Obviously, if they see anything in the meantime, you send them in. But otherwise, we'll have them go to their PCP after about, say 5 to 7 days or so, just to check out their blood pressure, heart rate, temperature, all that good stuff. If they're still looking good at that point, then they're probably going to be fine. So no real reason to watch that. But if it was like a really huge ingestion, you're still going to take about a week or so before you really see the full effects. In that case, there you might just have to hold the patient until you can really say, okay, well, we got to wait to see what goes on with their thyroid hormone and kind of go from there. But yeah, I've not run into a specific case of like overdose as a result or as a suicide attempt with levothyroxine. It's mostly just accidental kid ingestions for the most part. Okay. So just to get started here with the renal stuff, let's talk about acute kidney injuries. Now, this stuff is really important. I'm not going to be kidding around about any of these topics here, right? So you want to make sure you kind of get this stuff down, because it's not acute when this happens, right? It's an acute topic. Anyway, you'll see this happen a lot in patients, especially like in the in-hospital setting. If you work, in surgery, ICU, any places like that, ER certainly. This is where you're going to see, you'll have acute kidney injury usually as a result, or usually as evidenced by having abrupt reduction kidney function that's shown by creatinine bumping, BUN bumping, and typically urine output decreasing, right? The problem with this is that it has pretty high morbidity and mortality associated with it. It affects a ton of different things, including a lot of medications, and it's not something that's easily reversible too. So a lot of times we're having to treat through it. And then also a lot of times, like, we're the ones that did it to them. Not more often than not, but you'll see, you'll be surprised by the number of cases where it's like the drugs that we're using, or it's the therapy that we gave them that actually caused the kidney injury in the first place. And so that sort of iatrogenic sort of a kidney injury is not great, but it's just one of those things where sometimes you have to take the good with the bad there. So recognition is really key, because if you can at least identify and stop whatever the insult is, that's going to help to prevent further damage from being done. And hopefully it's going to be reversible. In some cases, it may not be, though. So we'll look at some cases here. But mainly our goals are, one, monitor the hemodynamic status, because you can see things like hypotension, hypertension as a result of this. We'd like to minimize the number of nephrotoxins they're on, and if we can, try to discontinue any offending agents. So, for instance, if they're on an aminoglycoside, do they need to still stay on that? Can we get them onto something else that's going to be less nephrotoxic? Are they on vancomycin? Can we move them to something else? Blood pressure management is important. Looking at things like fluid balance to make sure that the input and the output are matching, or at least are not in a state where they're going to get volume overloaded. And then also electrolytes tend to sort of go kind of haywire here as well, and results of things like potassium is a big issue. Salt, sodium is going to be a big issue. We find all kinds of problems here, and so we're going to look at ways we can try to help manage that in patients with acute kidney injury, at least with a drug-induced cause. And the reason why I talk about this too is because a lot of drugs can induce this, and so it's important to understand ways to try to mitigate that if we can, especially like chemotherapy drugs, antibiotics. A lot of things can cause acute kidney injury, and so if we can identify it and predict it, easier to avoid than if it were just kind of caught with their pants down, so to speak. Also, your patient has their serum creatinines tripled, and you're just like, well, how did that happen? It's like, well, it's because all the drugs you put them on, or they're hypotensive, or whatever the case may be. So anyway, you can see here there's various criteria for degrees of acute kidney injury, whether it has to do with their decreases in GFR, could be related to the serum creatinine. They need things like renal replacement therapy. That's what the RRT means. And certainly end-stage kidney disease, where they've been on replacement therapy for more than 3 months. That usually means like hemodialysis, renal replacement therapy, continuous renal replacement therapy. There's a lot of different modalities. I'll talk about a few of them as we go forward there. I'm not going to ask you specifics here in terms of like what stage someone is. That might come up on your CMS courses, but for my purposes, I'm just trying to illustrate to you what we're looking for. We're looking at things like serum creatinine, we're looking at urine output, we're looking at those sorts of things there, in terms of see like, okay, well, is the patient moving in the right direction? Is it the result of the medications we're giving them? Things like that. So here I want to kind of break them down into a couple of different varieties, and this probably looks a lot like what you saw when we were talking about pneumonia as an example. But you see here we can have community-acquired acute kidney injury. Normally here you're going to see it's not super common, but it's usually related to things like elderly patients. Maybe they're in the nursing home, not getting good care, not good PO intake or something. The hospital acquired you're going to see is more common. Usually it's going to either be due to a single or multiple causes, which may be medication included, but it could also be related to things like dehydration, volume depletion, not being able to supply the kidneys with enough oxygen-rich blood is going to be a big cost for this. So that's why like hypotensive patients usually develop kidney injury, and contrast dyes, things like that. And then the ICU acquired is going to be much more likely, because again, these patients have a whole host of issues going on. It's not just the disease states they present with, but it's also what they develop while they're in the ICU, what kind of therapies we're giving to them, things like that. They can have multi-organ failure, they can have septic shock, all kinds of problems here that can lead to acute kidney injuries. So one of the things we're going to do is try to determine, is this more of a pre-renal problem, an intrinsic problem, or a post-renal problem? Pre-renal just means it's an issue to do with decreasing perfusion to the kidneys. This is typically the easiest to fix out of the bunch here, and is most easily reversible if it's if it's pretty short in terms of a duration. If you can sort of fix this quickly, you're not going to really see a lot of long-standing damage here to the kidney, the actual parenchymal tissue of the kidney. With the intrinsic, this is where we're actually doing direct structural damage to the kidney itself. So if you think about things like amphotericin B, if you think about things like cisplatin, things like that, causing direct kidney injury, this is where you're going to run into the intrinsic sort of kidney injury. And then post-renal is usually like an obstructive sort of issue. So for instance, if you were having a patient who was taking androgens and they were causing their prostate to grow and cause obstruction of urine outflow, and which led to backflow to the kidneys, which led to injury, that's a post-renal problem. Or if you had a patient who developed, say, had issues where like a drug was crystallizing out in the urine collection system, and that caused a backflow to the kidneys leading to injury, that'd be a post-renal sort of problem. So specific drugs you'll find can cause more predictably one of these three, and again the treatment is going to be a little bit different depending on what situation there is. Again, here's a nice picture kind of showing you where the prerenal issues sort of come from, where the intrinsic issues happen here, and then anything past this is going to be a post-renal sort of problem. It can happen from the urethra through the ureter. Anything past the kidney itself can be considered a post-renal issue. And again, by identifying this, you can again hopefully identify good treatment for that. So, one of the things you're going to do, and again, I'm not going to get specifically into being able to diagnose it necessarily. I may ask you on a test like, okay, this drug does this. What is the most likely type of kidney injury it's causing? You know, that could potentially come up, and we'll go over some very specific examples coming up here. But as you're evaluating with these patients, of course, you're doing your typical history, you're doing your physical exam, all that stuff you're really good at, figuring out what labs to order and all of that. And then based off the labs you're getting there, you can determine whether it's a pre-renal, intrinsic, or a post-renal sort of issue there, right? And so these are some of the common things you're going to see with a pre-renal issue, typically related either to the amount of blood flow coming into the kidneys. That could be related to things like volume depletion, where there's just less blood flow available to go to the kidneys. Because remember, if your body's going to perfuse two organs, it's going to be the brain and the heart. Anything else kind of takes a back seat to that, which can lead to that pre-renal kidney insufficiency. And again, you can see lots of reasons for this. Maybe we're giving too much diuresis, and that's depleting blood volume. Perhaps the third spacing fluids because of septic shock or something like that. But you can also find that there's functional problems for this. Things like NSAIDs. You remember how they decrease inflow of blood to the glomerulus because they are clamping down on that afferent arteriole because you're decreasing prostaglandin synthesis, right? So there's functional reasons why that can happen here as well. So again, a lot of drugs can lead to this. That's why you should be able to predict this based off the patient's med profile. Intrinsic is going to be much more sort of diverse in terms of the different issues that can happen here, whether it's a vascular issue, an acute tubular necrosis. I'm probably not going to get super specific into the different varieties here, but we will go over specific drugs and how they can affect this. So certainly things like NSAIDs, certain antibiotics can cause an acute interstitial nephritis, but also think about things like myoglobin. Like, okay, well, is myoglobin really drug related? Because that myoglobin happens when you have muscle breakdown. Well, are there any drugs can cause muscle breakdown? Well, yeah, like vitamins can do that. We talked about neuroleptic malignant syndrome and having that lead pipe rigidity from an antipsychotic can cause rhabdo to occur if they develop malignant hyperthermia due to certain surgical anesthetics. You know, there's a lot of reasons why that can happen. So that's, again, that's why I'm just kind of illustrating some of the drug-induced causes because, again, these are easy things to identify and remove if possible. And then for post-renal, this would be the less common one we're going to run into, but this could be due to things like anticholinergic drugs or holding on to fluid, holding on to urine potentially, BPH, lots of different things can do this, and so we'll get into that as we move forward. So anyway, as I mentioned, the community-acquired acute kidney injury, probably most often this is going to be related to renal hypoperfusion. So, how would statins cause a drug-induced cause? Very good question, Isabel. Why do we think statins could do that? Where did they pop up here? Looking for statin. Someone can point it out to me. I'd appreciate it. Anyway, the big thing I would think about constriction of efferent arterioles. Yeah, so I think rhabdo would probably be the biggest one you would see there. So remember the statins. You know what happens if you have something like a CYP3A4 inhibitor and you're taking simvastatin, right? You would end up having basically having things like rhabdomyolysis develop, right? We talk about hepatotoxicity and rhabdomyolysis being the big thing. If all that rhabdo is occurring, you're leaching out all that myoglobin into the blood. All that gets filtered through the glomerulus. It gets clogged up in the kidneys and can cause more of an interstitial problem there, right? That's when you run up into that. Under volume depletion. Yeah, that one I would not consider to be statin related so much. That'd be more like a more diuretics and whatnot. But yeah, if I'm thinking a statin, I would certainly be thinking more so along the lines of rhabdomyolysis. So I think that's right on the money there. But again, we'll look at that in some more specific examples and how depending on the drug, you can kind of guess what type of kidney injury it might be able to cause based on its mechanism or based on the kind of side effects it can actually cause to occur. So we'll look at some examples of that as we go forward. I think I'm actually going to cut it there. I think I have a couple minutes left, and so I don't want to get too deep into this. I kind of want to just at least touch on the beginnings here, and now we can sort of get into more of the details as we go forward. So is there any questions I can answer before I let you all go? I think we meet again tomorrow at heck, I don't know, LOL. Well, I want to say that to a lot of things, to be honest. You guys ask me questions, I'm like, heck, I don't know. But I can try to make up some. I'm just kidding. All about confidence. You fake it till you make it. Other question to answer for you guys before I let you go. This was fat. Oh, well, thank you so much, Aaron. That's really nice of you. I think you're all fabulous. Oh, I was up to 599 subscribers. So again, this is only for my ego. I don't get any monetary gain from it. But if I could have one person subscribe, that would make me feel really happy. I'll probably end up having a reduction now. I'll probably end up having like, I don't know, like 550 by the time I get done with that. Some scornful viewers, perhaps. But anyway, yeah, you guys have a great day, and I will see you tomorrow. Oh, thank you, Kelly. I appreciate that. You guys are so nice. All right, I'll see you tomorrow. Have a great day, and I'll see you then.